Hello and welcome. I'm Fernando, a GP in the UK. Today we will go through the NICE recommendations on the management of acute kidney injury, focusing on what is relevant in primary care only. We will also cover the primary care flowchart on AKI by Barnsley Hospital NHS Trust and King's College Hospital NHS Trust. You can find links to them in the episode description. If you have not already done so, I recommend that you check the previous episode on AKI covering the diagnosis, investigations and recommendations on the use of contrast media. Right, let's jump into it. What management does NICE recommend? Well, managing acute kidney injury in primary care is generally limited, as it often requires specialized hospital monitoring and treatment. We're also likely to feel apprehensive keeping these patients in primary care, given the severity of some causes of AKI, such as sepsis, or some of the complications of AKI, such as acidosis and hyperkalemia. Although NICE does not spell out which cases can potentially be managed in primary care, some of the guidelines do provide us with some guidance, stating that primary care management can be justified, particularly for lower risk cases. I have looked at the guidelines on the management of acute kidney injury by Barnsley Hospital and King's College Hospital. But for now, let's stick to the NICE guideline. In terms of pharmacological management, we will not offer low-dose dopamine, we will not routinely offer loop diuretics, but we will consider loop diuretics for treating fluid overload or edema while awaiting renal replacement therapy or while renal function is recovering and the patient is not receiving renal replacement therapy. In terms of relieving urological obstruction, we will refer these patients to a urologist. We will do so as an emergency if there is pyonephrosis, an obstructed solitary kidney, bilateral upper urinary tract obstruction, or complications of acute kidney injury caused by urological obstruction. We will refer to nephrology those who need dialysis, but we will not refer those with a clear cause for the acute kidney injury if the condition is responding to medical management, unless they have a renal transplant. We will monitor creatinine after AKI, basing the frequency of monitoring on the renal function at the time of discharge. We will refer to a nephrologist if eGFR is 30 or less post-AKI recovery. We will refer to a pediatric nephrologist anyone under 18 years who after AKI have hypertension, impaired renal function, or 1+ or greater proteinuria on dipstick testing. Let's now review the guidance provided by King's College Hospital and Barnsley Hospital. Since both pathways are quite similar, I'll primarily focus on the flowchart from Barnsley Hospital NHS Trust, because it is better to navigate clinical cases, but I'll be sure to highlight any supplementary details from King's College Hospital along the way. Right, so we start with the flowchart at Barnsley Hospital. And if we get an AKI alert, then we have to look at the stage of the AKI that we're dealing with. So let's have a look at them. We have stage 1, which is when creatinine rises by between 1.5 and 1.9 times from normal baseline. King's College Hospital also includes here a rise of creatinine by 26 micromoles per litre within 48 hours, which is in keeping with NICE recommendations. Stage 2 is when creatinine rises by between 2 and 2.9 times from normal baseline. And stage 3 is when creatinine rises by 3 or more times from normal baseline. King's College Hospital also includes here when creatinine rises to 354 micromoles per litre or more. Then we see that stage 3 AKI will require admission to hospital, but admission to hospital will also be needed in a number of other cases. Let's go through the list. So not only stage 3 AKI, but also if the patient is clinically unwell with suspected sepsis and/or has the high NEWS score. Remember that NEWS stands for National Early Warning Score, which is used to assess the severity of a patient's condition especially in cases of sepsis or other acute illnesses. If you're not familiar with it, I have put the link for a news calculator in the episode description. We will also admit to hospital patients with any AKI stage with no clear cause, or if there is an adequate response to initial treatment, a possible diagnosis that may need specialist treatment, for example, AKI with suspicion of urinary tract obstruction or intrinsic renal disease, pregnancy, urinalysis showing both 2 pluses of blood and protein, although here King's College recommends admission if urinalysis shows either 2 pluses of blood or protein in the absence of UTI, so no need to have both, either one in isolation would be enough to warrant admission. We will also admit to hospital patients with systemic symptoms, for example, arthralgia, rash, epistaxis, or hemoptysis, when we will think of glomerulonephritis, vasculitis, interstitial nephritis, or myeloma. We will also admit if there are AKI complications like hyperkalemia with a potassium of more than 6, fluid overload, or uremia. Also, if there is prior CKD stages 4 or 5, that is an eGFR below 30, and a renal transplant with any AKI. And so, in all these cases, we will refer to the medical team, considering discussion with nephrology or urology, depending on the clinical presentation. And therefore, the implication is that AKI stages 1 and 2 can potentially be managed in primary care. So in these cases, we will ask ourselves, is the patient acutely unwell? Are there AKI complications? Is there a need for IV fluids or worsening AKI? Or any other ongoing concerns? And if the answer is yes, we will admit them to hospital. But if the answer is no, then we should be able to manage them in the community. For this, we will need close follow-up, early repeat of creatinine and monitoring of potassium, carry out the process of stop AKI, which we will look at in a minute, and review the patient clinically within 24 to 48 hours, using the rapid response team if necessary, and discussing with the medical team if there are any ongoing concerns. So, what do we need to do in respect of the stop AKI process? Well, stop AKI is a systematic approach where each letter in stop represents a critical component of AKI management, aiming to reduce complications and support kidney recovery. So S is for sepsis, where we should recognize and treat infection. We will do urinalysis, and if there is protein, leukocytes, or nitrites, we will send an MSU and start antibiotics. King's College Hospital recommends that if there is infection, we should not prescribe trimethoprim or nitrofurantoin because of increased risk of toxicity and, in the case of nitrofurantoin, reduced efficacy in AKI. We should also check a full blood count and urea and electrolytes at least every 48 to 72 hours until the patient is clinically stable. T is for toxins. We should hold nephrotoxic drugs like, for example, non-steroidal anti-inflammatory drugs, ACE inhibitors, ARBs, nitrofurantoin, and allopurinol. O is for optimize blood pressure and fluid state. If the patient is dehydrated, we will encourage oral fluid intake. If there is fluid overload, we will refer to the medics. If the patient is hypotensive, we will obviously stop any antihypertensive and diuretics until the situation is stable. P is for prevent harm. We will do a drug review and apply sick day rules like, for example, stop or adjust the dose of metformin because of the risk of lactic acidosis, proton pump inhibitors, which can worsen electrolyte imbalances, opiates, because they can accumulate during AKI, and in the case of specialist drugs such as sulfasalazine or lithium, we will discuss it with a relevant specialist. Obviously, we will always aim to identify the AKI cause, thinking of pre-renal causes, intrinsic renal disease, and obstructive causes. In this respect, King's College Hospital emphasizes the need to exclude a palpable bladder during examination and requesting an ultrasound of the urinary tract in patients with stage 2 AKI. So that is it, a review of the management recommendations on AKI. If you have not already done so, please check the previous episode covering the diagnosis and initial investigations of AKI. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for watching, and goodbye.